Can everybody hear me?
Yes.
Yeah.
Okay, good.
Here.
Congrats on completing your first quiz. I hope you guys enjoyed it. So we'll be going through the TA questions. Hold on, wait, let me admit somebody 1 second. So we're just gonna run through the TA questions really quick. So I'll start off first with anatomy and then we'll go down from there. And if you have any questions, I'm gonna share my screen and we'll go over through the answers. Please feel free to let me know if you have any questions in between. And yeah, we'll proceed right through, and then feel free to ask us questions at the end because we'll have a Q&A and we'll be able to answer any questions that you have regarding the material or anything else you're concerned about. So I'm gonna share my screen right now. Give me 1 second.
Justin, I have a quick question.
Yeah.
The questions that you wrote pretty reflective of his questions?
Oh, so for the anatomy quiz, right?
Yes.
Yeah, I feel like the questions were pretty reflective. Yeah, as we move on throughout the TA sessions, like as the weeks go on from Friday to Friday, I feel like the questions are definitely going to get more difficult because you're going to have more material. Things are going to be building upon each other. So for now, yeah, I think it is definitely reflective of the material that Dr. Muffy will be quizzing on.
Thank you so much.
Yeah, of course. Okay.
The answers to the practice test, are they going to be accessible, or we have to come to the review session in order to get them?
Wait, can one of the TAs hop into that? I'm not too sure about that one right now.
So from my understanding, we were going to allow you to see your correct answers, but after our session has taken place, so we'll go over the correct answers with you, and then we will unlock the quiz.
So I will be able to see the correct answers after this on the quiz directly.
Yeah. So you can use that quiz to study from. You'll have the correct answers there. So if you want to review that material before the exams come closer to exam time, you'll be able to with the correct answers and see the questions and everything.
All right. I'm going to share my screen right now. Okay, so can everybody see my screen?
Yes.
Okay, so I'll start with the first question. Hopefully they stood in order. Let me know if they didn't, but I'm going to go through the order that I have them in, and then I'll just explain the answers one by one, okay? So for the first question that was for anatomy, it was which of the following is not part of the axial skeleton? So the correct answer is the humerus. Remember, the only thing that is part of the axial skeleton will be the vertebral column, which consists of the cervical vertebrae, the thoracic vertebrae, the sacrum, as well as the coccyx, and the ribs as well. Those are all going to be part of the axial skeleton. So the humerus is not part of the axial skeleton. Great job, y'all. You did really good on that question. So for the next one, it was going to be, so you are completing your rotations in the hospital when you come upon a patient with subluxation, which is a partial dislocation in a spinal joint that is causing vague neck pain and occasional intermittent cervical spinal cord compression. The patient describes that they are unable to rotate their head from side to side due to the pain. What is the type of joint that is affected? So with this question, it's a little bit more clinical based, but if you read the key thing that's going to be, hold on, let me see if I have an arrow. I don't think I have an arrow pointer. But the key thing of this entire paragraph is going to be they are unable to move their head from side to side, right? So if we know side to side, we're like, okay, that's the no joint. So that's going to be the AA joint, so the atlantoaxial joint. So if you know that atlantoaxial joint is going to allow you to move your head from side to side, then you know that it's going to be a pivot joint. So yes, that is correct. That would be a pivot joint. So saddle joint would just be the carpal metacarpal joint in your first metacarpal, which would be your thumb. Conoid joint, for example, would be the metacarpal, the phalangeal joint, which would be the joints between your phalanges and your metacarpals, which we talked about in the TA session. A hinge joint would be, like, for example, your elbow. Your elbow would be a hinge joint. Oh, wow. Okay, so the next one is you are analyzing virtual cuts, right? So in a coronal planar field, if the images begin from ventral to dorsal, which structure would be the one you first see? So again, you have to first understand what the coronal planar field is. So coronal planar field is the same thing as saying frontal, right? So you're just cutting the body you're cutting the body into sections that you can see from anterior to posterior. Remember, with frontal, think I can see the front side of my body, right? So you're going to be cutting from anterior to posterior. So the images begin from ventral to dorsal. Which structure would you see first? So is it going to be the latissimus dorsi, rhomboid minor, pec minor, or trapezius? And that is correct. You all put the pectoralis minor because the latissimus dorsi, the rhomboid minor, and the trapezius are going to be back muscles, right? So if you were to take sections in the front, obviously any muscle that's going to be in the ventral side or the anterior side of the body is going to be the first one that you see. So the pectoralis minor by default will be the first one that you see. So the next one we're going to have is going to be a patient comes into a clinic with pain/numbness in one of their legs. After multiple tests, the patient is diagnosed with spinal stenosis, which is narrowing of the spinal column. The physician desires to perform a laminectomy, so removal of the lamina to ease the pain. Due to the loss of laminas, the patient lost the connection between what? So this is when you have to understand the difference between the lamina, the pedicle, as well as the superior and inferior articular facets, right? So if you remember, the lamina is going to be connecting the transverse process to the spinous process, correct? Most of you did very well in that question. The vertebral body to the spinous process is actually not even a connection. I just put that in there. But the vertebral artery to the transverse process would be the pedicle, right? And then you have vertebral artery, the vertebral body to the adjacent vertebrae body is going to be the superior and inferior articular facet. So yes, it is going to be the transverse process to the spinous process. So I tried to make a lot of these questions like as clinical as possible. So you guys get like a real world understanding of like the topics that we're going through in anatomy. So for example, and during this question, I wrote, John is a world-class weightlifter and has been competing in the field for over 15 years. During one of his normal workout routines, John notices some pain within the medial border of his scapula. John goes to the clinic and the physician observes that he has a decreased ability to elevate and adduct his scapula. The physician diagnoses him with dorsal scapular nerve entrapment, which can occur in weightlifters within their scalenus medius muscle. Which other muscle will be able to compensate for the lack of elevation and adduction in the scapula due to the dorsal scapular nerve entrapment? So if you remember that the trapezius, remember dear trapezius, right? So the D is going to stand for depresses. E is going to be elevate. So elevate would be one. A would be adduct, and then R would be rotate the scapula upward, right? So again, elevation and adduction will be completed by the trapezius because it is not supplied by the dorsal scapular nerve, right? Since the dorsal scapular nerve is entrapped, that means any muscle that's going to be innervated by dorsal scapular nerve will be unable to complete its action. So for example, the levator scapulae, the rhomboids major and minor, etc. So which of one of these muscles will be able to allow elevation and adduction? And that would be the trapezius. Serratus anterior is going to allow for protraction. So this is going to be called the boxer's muscle. This is what allows boxers to throw punches, straight up powerful punches. The serratus posterior superior, that's by the intercostal nerves. And then you have latissimus dorsi, which is going to be by the thoracodorsal nerve, right? And that's the latissimus dorsi is not going to help with the elevation of the scapula. So yes, trapezius is correct. So the next question we had, the bicipital groove is an important attachment point for many muscles. Oh yeah, feel free to like interrupt if you have any questions in between. Like I don't mind answering them as we are like at the question. So which muscle attaches to the medial lip of the bicipital groove? So we have the long head of the biceps brachii, the short head of the biceps brachii, the pectoralis major, and the latissimus dorsi. And most of you got that correct. It is the latissimus dorsi. Remember, the pectoralis major is going to attach to the lateral lip of the bicipital groove, right? Short head of the biceps brachii is actually going to attach to the coracoid process. And you have the long head of the biceps brachii, which is actually going to attach to the supraglenoid tubercle of the scapula, remember? So yes, you all did very well in that one.
Justin?
Yes.
I had a question, sorry, about back on 17.
Oh, no, you're good. Wait, was that
this one with the trapezius?
Okay, yeah.
Wasn't there, so I know the trapezius does most of the movement of the scapula, but wasn't there one that assists with like the rotation of the scapula?
Yes, so the trapezius allows for upward rotation of the scapula. Yeah, so And then the levator scapulae is going to be another muscle that actually also helps with the elevation of the scapula. But you have to remember that the levator scapulae is innervated by the dorsal scapular nerve, so that wouldn't be able to like be working if dorsal scapular nerve was entrapped.
Gotcha. Okay, thanks.
Yeah, gotcha. Okay, and then next one. So yeah, I inputted a picture here. So the nerve supply for this muscle superior to the cephalic vein shown here is compromised. What is the nerve supply of that muscle? So you would have to, not only would you have to identify the muscle that is superior to the cephalic vein, you would actually also have to know the innervation of that muscle as well. So I would say this is like a two-step question. And most of you did get that correct. That is right. That is going to be the axillary nerve, right? So the axillary nerve is going to innervate the deltoid muscle. The muscle just to the right of that, I guess, or medial to that would be the pectoralis major, right? The pectoralis major is going to be innervated by the medial and lateral pectoral nerve, which is what I put in C. The radial nerve is going to do the entire posterior compartment of the arm. And remember the musculocutaneous nerve, that's the nerve that actually penetrates directly through, basically just like stabs right through the coracobrachialis, which is going to supply the entire anterior compartment of the arm. So yes, you guys did really well with that. Remember axillary nerve. And that's actually going to go to the quadrangular space as well. Remember, only AP students can get through the quadrangular space. So you have the axillary nerve as well as the posterior humeral circumflex artery, which is going to go through the quadrangular space. So which of the following do not have an attachment point to the coracoid process? So the answer is going to be B, right? Because remember, the long head of the biceps brachii, if you saw my review, is actually going to attach to the supraglenoid tubercle of the scapula, right? So it's actually going to attach to a different spot. The pectoralis minor, the coracobrachialis, and the short head of the biceps brachii is going to attach to the coracoid process. One of the reasons why I put this question in here is because it also gives you like kind of like a chart of things that attach to the coracoid process. So yes, the answer is going to be not, but now you have like 3 answers that are going to be the ones that attach to the coracoid process. So now you know 3 muscles, the pectoralis minor, the coracobrachialis, as well as the short head of the biceps brachii are all going to attach to the coracoid process. So for this one was really interesting. So Muhammad Ali is known as one of the most world-renowned boxers to ever step foot into a boxing ring. It is agreed among many that boxers at this level have remarkable strength in protracting their scapula, helping them to throw their powerful punches. What is the most probable nerve supply of a muscle that allows for such protraction of the scapula? So for this one, it's going to be the long thoracic nerve, right? It's going to be the long thoracic nerve because the serratus anterior is going to be the muscle that's going to actually promote protraction of the scapula. It's actually also called the boxer's muscle. So if you look up like serratus anterior muscle, boxer's muscle, you can actually see some pretty cool facts and pretty cool history about that serratus anterior being very important for boxers. The dorsal scapular nerve, on the other hand, that's going to supply the rhomboids as well as the levator scapulae. So if we remember where those are actually placed anatomically, those are actually going to help with elevation of the scapula as well as retraction, right? So it's basically pulling the scapula back. It won't help with protraction. The suprascapular nerve, which is going to innervate the supraspinatus as well as the infraspinatus, is going to be a rotator cuff muscle. So that's not going to be involved with protraction of the scapula either, because that's going to be stabilizing the humerus inside the glenoid cavity. And then the ulnar nerve, which we really didn't talk about too much, but the ulnar nerve, like we said, is going to be mostly, well, we'll talk about that later on because we haven't had a lecture on that, but it's mostly going to be in the anterior forearm. I think I have like 2 or 3 more left. Okay, so for the Saturday night palsy, so I found this really interesting. So Saturday night palsy is actually due to compression of a certain nerve to a firm object, usually a chair or bar stool, commonly due to alcohol intoxication, right? So picture like somebody like sitting on a chair and their arm is behind the chair and their arm is pinched to their body on the chair. So in that position, basically, is usually due to alcohol intoxication. You can actually pinch your radial nerve if you like stay there for too long. So that's called Saturday night palsy, right? So it leads to an inability to extend the elbow. So like I said, which nerve is affected due to this compression? So the fact that I put inability to extend the elbow, you should know that that is going to be the radial nerve, because the radial nerve is going to cover the entire posterior compartment of the arm, right? Ulnar nerve, we didn't talk about too much. This is going to be the anterior forearm. Musculocutaneous, remember, that's going to puncture the coracobrachialis, and it's going to help with flexion at the arm. And then you're going to have axillary nerve, which is deltoid muscle, as well as teres minor. So for this one, which artery supplies most of the posterior compartment of the arm? So that's going to be the deep brachial artery, right? So the brachial artery is mostly going to be in the anterior compartment of the arm, but remember the brachial artery branches off into the deep brachial artery, which is going to supply the posterior compartment of the arm. Remember, it's really important to note like that the deep brachial artery as well as the radial nerve are going to go right through the spiral groove. That's super important. That deep brachial artery and radial nerve go through the spiral groove together. The thoracodorsal artery is going to supply the latissimus dorsi, and the superior thoracic artery, you don't need to know too much about that, other than it's going to be coming off the axillary artery. And this is the last one. So this nerve allows for flexion of the anterior arm. On a cadaver, you can identify this nerve quite easily because it is usually penetrating the coracobrachialis muscle. Which nerve is this? And that is correct. It is going to be B, the musculocutaneous nerve. The median nerve, that's actually going to go into the anterior forearm, mostly towards the wrist. That's actually going to be the nerve that's going to be irritated during carpal tunnel syndrome, is going to be the median nerve. Musculocutaneous nerve is going to be, like we said, anterior flexion of the forearm, anterior flexion of the arm, excuse me. Radial nerve is going to be the entire posterior compartment of your arm and forearm, and axillary nerve will be your deltoid as well as your teres minor muscle. So if anybody has any questions for me, let me know, but if not, I'm going to pass it on to the next one, the next TA.
Justin, real quick, what did you say that the long head of the biceps brachii does attach to if it's not the coracoid process?
Yeah, the long head of the biceps brachii is actually going to attach to the supraglenoid tubercle of the scapula.
Thank you. Yep.
Gotcha.
Can you go back to the answer for question 14? I think I missed your explanation on it.
Yeah. Which one was 14? Let me know when to stop.
It's the rotations in the hospital question.
Oh, okay. Okay. So basically, it's just talking about someone who's doing rotations in the hospital and someone's coming in with vague neck pain and cervical spinal cord compression. So basically, the main thing about this clinical vignette is the side-to-side pain in the head. So if you remember, what is going to be the joint that is going to allow the head to go side to side? That's going to be the AA joint, which is going to be the atlantoaxial joint. That's going to be between C1 and C2, and that's going to allow the head to pivot from side to side. So it's going to be the pivot joint right there, which is going to be B. The saddle joint, like we talked about before, is going to be located in the thumb, and that's going to be between the carpals and the metacarpal of the first metacarpal joint, which is just basically a fancy way of saying in the thumb, basically. You're going to have the condyloid joint, which is going to be between the metacarpals and the phalanges, which is between like the metacarpals, which would be extending in the palm of your hand, which are connecting to your phalanges, which are your fingers, right? Those are going to be, so basically your knuckles. Your knuckles are your condyloid joints, right? And your hinge joint, for example, would be your elbow joint. Did that help?
Yes, thank you.
Yeah, I got you.
Justin, I actually have a question regarding number 15. That was the one with the virtual cuts.
Yeah.
I'm not really sure how you would see the pectoralis minor first because I'm not sure. I guess I'm just kind of confused on the orientation and what would you see from ventral to dorsal.
Yeah, so when you're cutting in the virtual plane of field for a coronal, basically it's the same thing as saying frontal. So when I put on my slides, so when you want to think frontal, think you're able to see the front of the body. So you're cutting the body in order to see anterior to posterior. So if you're starting the cuts basically like from anterior to posterior, as you move back, you'll be able to see like more and more muscles basically. So if you start from the front, which is anterior, also known as ventral, you'll be able to see the pectoralis major and then the pectoralis minor, and then eventually you'll see like the spinal column, and eventually you'll go into the back muscles, right? So you see what I'm saying? So you're going from ventral to dorsal. So the only one you'll be able to see first is the pectoralis minor, because that's not going to be a back muscle like the latissimus dorsi, the rhomboid minor, and then the trapezius. These are all located on the posterior side of the body. The pectoralis minor is actually located on the anterior, also known as the ventral side of the body.
All right, thank you.
Does that make sense?
I believe so. Thank you.
Okay, yeah, for sure.
Could you go over the second to last one?
Yeah, the second one. This one, right? Which artery supplies most of the posterior compartment of the arm?
Yes.
Okay. Yeah, so what's going to happen is that you're going to have the subclavian artery, which turns into the axillary artery, which eventually turns into the brachial artery. Once it turns into the brachial artery is going to branch off into the deep brachial artery. The deep brachial artery is going to go into the posterior compartment of the arm. And when I say arm, I mean the region between the shoulder and the elbow, right? Because from the elbow to the wrist, that's actually going to be the forearm. That's what they identify it as. So the posterior compartment of the arm is mostly going to be supplied by the deep brachial artery, because the deep brachial artery is going to be a branch of the brachial artery that goes straight to the posterior compartment. The brachial artery is going to stay more medial, so it's going to stay more towards the medial anterior side of the arm. So the brachial artery is going to supply most of the like the biceps brachii, like the coracobrachialis, the brachialis, etc. The deep brachial artery is going to go to the posterior compartment and it's going to supply the triceps brachii, which would be on the posterior compartment of the arm. So yeah, it's just basically branching off the brachial artery.
Okay, thank you.
Yeah, for sure.
I have a quick question. Sorry, I came in a little bit late. Can you just show me the answer for the one that was like with a picture asking like what nerve, the muscle picture?
Yeah, that's one. Do you want me to explain it, or
okay.
Are you good?
You could. I just wanted to see. I didn't know the answer. Thank you.
Okay, gotcha. Yeah. Okay. Any more questions? All right. Okay, I'm gonna pass it off to, I think it's biochemistry, right? So I think Phoebe, yeah.
Hey guys. So it looks like some of my questions were real tough. So don't freak out. I tried to make them a little bit more reflective of the harder questions that you'll see on this first exam. I feel like 50 to 60% of them were pretty straightforward. So hopefully they're good study material and help you understand it a little bit better. So I'm gonna share my screen now. And if you have any questions, just, interrupt me. Okay, hopefully everybody can see my screen. Okay, so a patient with a history of diabetes presents to the ER in a comatose state. Following a blood draw, it is determined that the patient's blood is 6.6. So automatically you know that that's acidosis, right? Because it's below 7.4. Knowing that the pK of carbonic acid is 3.6, what is the ratio of bicarb to carbonic acid in his blood? So the way you would find the answer to this is you would have to use the Henderson-Hasselbalch equation. So if you put 6.6 equal to 3.6 plus the log of base over acid, you're solving for this ratio right here. So when you subtract 3.6, basic algebra gives you 3, and then to find the ratio, you have to solve for log, get rid of the log. And so it's 10 to the 3, which is equal to 1,000. So your ratio is 1,000 to 1. So it's that answer. Okay. For the next one, if a patient's blood pH were 7.6, what would his condition be considered and what may be causing it? So for this, we know that it's above 7.4, so you automatically know that it's alkalosis. So you can cross out the acidosis option. And we know that with alkalosis, you're going to have a drop in the proton concentration. And remember that carbon dioxide is essentially what's causing an increase in the proton concentration. So it would be a loss of carbon dioxide through hyperventilation in this case that is causing alkalosis. For the next question, to determine the pH range at which histidine exists as a zwitterion, a researcher wants to determine the amino acid's pI. Given the following, and then you got all your pKs, what is the pI of histidine? So for this, you have to understand that histidine is a basic amino acid, so you have to use the pI formula for basic amino acids. So we know that the pK for the amino group, which is the one you have to use for a basic amino acid, is going to be around 9 to 10. So that has to be this pK2. And then you're also going to use the R group. So you add 6 plus 9.17 and then divide it by 2, and you should get somewhere around 7.5, and that's like the closest answer to that. Okay. So which of the following is not true about the alpha helix? So this is mostly just memorization. So the alpha helix R groups that the alpha helix has R groups that point towards the outside of the spiral. We know that the R groups point outward because remember that the alpha helix center is too tiny to be able to accommodate for large R groups. So that's true. There are 3.6 amino acids per turn. That's also true, unless you're talking about collagen, which only has 3 amino acids per turn. The alpha helix is held together only through hydrogen bonds. Remember, the alpha helix and the beta sheets are both secondary structures, and for secondary structures, you're going to have hydrogen bonding only, holding those together. So it has to be this one, where alpha helix is composed of reverse turns. Remember that reverse turns are their own type of secondary structure, so it's not what makes up an alpha helix.
Hey, Phoebe.
Yeah.
Going back to that last question.
Yeah.
Where would we start seeing disulfide bridges and bonds?
So you would start seeing that when it's forming the tertiary structure. Does that make sense? So you would see all of those. So secondary is only hydrogen bonding, and then the disulfide would be part of the tertiary structure.
All right. Thank you.
You're welcome. Okay. A researcher isolates an unknown tridepeptide in order to identify the sequence. The researcher adds trypsin, which cleaves off a glycine residue. So right off the bat, you have to understand that trypsin is going to cleave off arginine or lysine at their carboxyl ends. So in all of these options, you only have arginine. So if you were to cleave off this, it would have nothing. If you cleaved off this, you would have your tryptophan. You have nothing if you cleave it off this end, and then you would have a glycine if you cleaved it off this end. So automatically you can assume that this is the answer, but if you didn't know that about trypsin or you didn't remember, then you can go on to the rest of the question. So he adds chymotrypsin to the dipeptide, so whatever is left, meaning that it had to have cleaved something off, and that cleaves off a tryptophan. So remember that chymotrypsin is going to cleave off aromatic amino acids. So in this case, it would have had to cleave off the tryptophan itself. So when you cut off the carboxyl end of the tryptophan, you're going to be left with a tryptophan and a glycine. And in this case, it would be this one this one, because it cuts them all into 3 separate amino acids, and it's the only one that would fit with the answer choices. Okay. Following the identification of the primary structure of the protein, the scientists are interested in determining the secondary and tertiary structure for it. Which methods would be best to determine each of these? So this is really just a memorization question. And remembering that secondary is you find it through circular dichrosum spectroscopy, and then tertiary is X-ray crystallography. So pretty straightforward.
Hey, Phoebe.
Yeah.
For that question, what's the difference between circular that spelled out versus just saying CD spec?
Oh, it's the same thing. I just used 2 of the same word just to kind of trick you guys. So really, it's the same thing. You can have either or.
Oh, so there's 2 correct answers for that question?
Oh, I said respectively. Did I put both? Okay, yeah, no, the word respectively would be, so first you would have secondary and tertiary, and then you'd have to show them in order. Sorry, that was a little bit of a trick.
Thank you.
Yeah.
And which one can you use mass spec for again?
That is for primary structure. So, you use it to identify the amino acids.
Thank you.
You're welcome. Okay. The formation of collagen is important for the structural component of many different tissues. Which of the following would cause an inability to form covalent crosslinks between the triple helices in a fibril? Remember that covalent crosslinks are going to happen between hydroxylysines and lysines. So you automatically know that it's going to involve the enzyme that forms these crosslinks between the lysines and the hydroxylysines. So it's obvious that this is the answer. The prolyl hydroxylase would just hydroxylate the proline groups, and that's really not important for cross-linking. And then for glycosylation, that's also just to stabilize the triple helix, so that's also not important for that. And then we're talking here about the same kind of thing as this thing. So if you have a mutation in prolyl hydroxylase, you're unable to hydroxylate the proline residue, so it's pretty much the same wrong answer, just worded differently. Okay, so which of the following statements is false with regard to collagen? It is composed of 33% glycine residues with a high amount of proline residues. So yeah, this is true because remember every third amino acid is glycine, so that would comprise 33% of the collagen. And then obviously we have a lot of proline residues as well. It is composed of 3 left-handed alpha helices. Remember that this is also true. The alpha helices in collagen will be left-handed, but together they become right-handed. It has low solubility in water. Remember, this is an important component for fibrillar types of proteins, so this is also true. Glycosylation of hydroxylysine residues involves the attachments of glucose and lactose. This is wrong because it's glucose and galactose, which would be the right answer. So you guys did good with that. Okay. A pirate who got back from several months at sea comes into the ER complaining of fingernail decay, tooth loss, and liver spots. Which of the following is most likely to cause his symptoms? So automatically, if the pirate didn't give it away, I also added the 3 symptoms that are on the slides that are, talking about scurvy. So you have to know that first it has to be scurvy, and then you have to understand why scurvy is the way it is. So I see that this was kind of a tricky question for some of you. So remember that with scurvy, because you don't have vitamin C, you're unable to use vitamin C as a cofactor for when you're hydroxylating the proline and lysine residues when you're doing a collagen synthesis, right? So that's on the slide there, and automatically, if you don't have vitamin C, then you can't do that. The reason why this is wrong is because although decrease ascorbate in the body, that is a true statement. The enzyme is wrong. This is lysyl amino oxidase, which is the enzyme for forming the covalent cross links, not the enzyme necessary to hydroxylate the prolines. Okay. What kind of oxygen dissociation curve would be demonstrated by a globular protein with a Hill coefficient equal to 1? So knowing that the oxygen dissociation curve is going to be the curves that either look like this if it's hemoglobin, or like this if it's myoglobin. So you have to understand that, and that with a Hill coefficient equal to 1, it's going to be a non-cooperative type of protein. So then it would have to be hyperbolic, which is what you would see in myoglobin because it's a non-cooperative protein. Okay. A weightlifter is doing bicep curls with heavy weights over a long period of time, causing lactic acid buildup and an increased metabolic rate in his biceps. Which of the following is true in this scenario? So remember that when you're doing weightlifting over a long period of time, your muscle will ultimately run out of oxygen, and you'll start doing anaerobic respiration, which leads to a buildup in this lactic acid and an increase in your proton concentration. You're also going to have an increase in carbon dioxide because remember, in your tissues, you have just regular metabolic processes. So compared to your lungs, your carbon dioxide is going to be low in your tissues, and higher in your tissues, and as is your proton concentration in this example. So you know that when you, because of the Bohr effect, you have the curve will shift to the right, meaning that you're going to have a lower affinity for oxygen. So this would essentially promote the release of oxygen from hemoglobin when you have an increase in these two, because it allows hemoglobin to know where it is in the body, and it also know that this particular tissue in this region needs more oxygen, so I need to dump out a bunch of oxygen for this tissue to receive it. But you guys did pretty well on that question. Okay, so compared to hemoglobin, myoglobin, so this is just another memorization question, understanding the difference between hemoglobin and myoglobin. So myoglobin has greater cooperativity than does hemoglobin, and therefore forms a hyperbolic curve. That's false because it does not have cooperativity. Has a Hale coefficient greater than 1. Remember, if the Hale coefficient is greater than 1, then it would also show cooperativity, which is also false. Has quaternary structure that is conserved. It doesn't have quaternary structure. Remember, it's just a monomer. It's the hemoglobin that has quaternary structure. And then has a greater affinity for oxygen at a lower PO2. Remember, yes, this is why it has a hyperbolic curve, because it's really good at grabbing oxygen when the oxygen concentration is low. And I think that's the last of my questions. So does anyone have any questions about any of that?
Phoebe, can you please go over question 31 again?
Which one is that one?
The formation of collagen is important for...
Am I passing it?
This one.
This one?
You're on it now.
Oh, so the tripeptide one, is that what you're asking?
Mm-hmm.
Okay, so remember that when you add trypsin to something, it's going to cleave off the carboxyl end of the amino acid. So whatever's on the carboxyl end of the amino acid gets cleaved off. So in this case, trypsin is specific for arginine.
Oh wait, sorry. You were on it, and then I guess it was a lag. I think it's the one
This one?
It's the one that says the formation of collagen is important for the structural component.
Oh, okay,
Right
yeah.
below that one.
Yeah, this one. The formation of collagen is important for the structural component of many different tissues. Which of the following would cause an inability to form covalent crosslinks? Okay, so the covalent crosslinks, remember that that's between the hydroxylysine and the lysine groups. And it's that whole picture that shows all those aldehydes being made, and then they, react with each other and form the crosslinks. So remember that you have to memorize the enzyme for that. So if you have a mutation in the lysyl amino oxidase enzyme, it's no longer going to be able to form those crosslinks. So that would be most likely the right answer. This is wrong because the hydroxylation of proline has nothing to do with the formation of the crosslinks, because it's the hydroxylation of the, it's the covalent bond between the lysines or the hydroxylysines that make these crosslinks. This is also wrong because it's also the wrong enzyme. It's the enzyme that hydroxylates the proline groups. And then the glycosylation has also nothing to do with the formation of these crosslinks. Does that answer your question?
Yes, thank you.
You're welcome.
Could you go over the amino acid cleaving?
Okay, yeah, the one I was just on previously?
Yes.
Okay. So for this, remember that trypsin is going to cleave the carboxyl end of either arginine or lysine, but because none of the answer choices have lysine, you can automatically assume that we're talking about arginine. So if you cleave off the carboxyl end of arginine, you're going to get nothing in option number 1. If you cleave it off the second one, then you'll get a tryptophan. You'll get nothing in the third option, and then for this option, you'll get a glycine, which is consistent with this statement right here. So you can automatically say, okay, that has to be the right answer. But if you wanted to read the rest of the question because you forgot what trypsin cleaves off, then you need to know that chymotrypsin is going to cleave off any of the aromatic ones, so that in this case, it cleaves off a tryptophan. So knowing that it cleaves off the tryptophan, which is what it acts on, you have to know that tryptophan is going to be the first option because it's the one getting cleaved off by itself. So in this case, if you cleave the carboxyl end of the tryptophan, you get a tryptophan and an arginine, but we didn't really talk about that. So this is the only one that is consistent with both of those statements. Did that answer your question?
Yes, thank you.
You're welcome.
Hi, Phoebe. Can you go over the pH question, please?
Was that the first one?
It was the one 1,000 to 1 was the answer.
Oh, okay, yeah, the first one. All right. So for this one, when you see pH and pK in the same statement, you can automatically assume that we're comparing the two, and the only way to compare the two is to look at the Henderson-Hasselbalch equation. Oops. Okay. So when we put it into the Henderson-Hasselbalch equation, so you're doing 6.6 is equal to the pK, which in this case is 3.6, and you're adding the log of the base to the acid, because remember, we're finding the ratio of bicarbonate, which is the base, to carbonic acid, which is the acid in this case. So when you solve for that, you're going to get 3 is equal to the log of base over acid. And then to solve for the log equation, you just put base 10 and it cancels out to both sides. And so 10 to the 3 is 1,000 over 1 essentially, and that's equal to base over acid. So you can say it's 1,000 to 1. Does that answer your question?
It does. And will questions ever ask us to give the reverse, like the ratio of acid to base?
Well, you could do the reverse. Honestly, you could just flip this equation, and then it would be 1 to 1,000 in this case. But I don't think she would make it that complicated.
Okay, thank you, Phoebe.
You're welcome.
I had a question.
Yeah.
With the unknown tripeptide, sorry, not that one. The one with the different pHs, and you had to calculate with like PK1, PK2, and the PKR.
This one?
Yeah. How did you know, or how did you come to the conclusion that you had to take the average of PK2 and PKR?
Okay, so we know that this is a basic amino acid. So memorizing that equation is for a basic amino acid, you have to find the pK of the amino group and add that to the pK of the R group. And that's just the equation that you have to memorize. So remember that the amino group, its pK value is going to be somewhere between 9 and 10. So it can't be this one. That has to be the carboxyl group's pK. So automatically, you know, it's going to be 9.17. And then she'll label this as PKR, indicating that this is the R group. So that's how you would know which ones to use. Does that answer your question?
Yeah, I had just forgotten the equation. Thank you.
No problem.
So when will we use the neutral equation?
So that would be with like hydrophobic amino acids. So the ones you would memorize, you know, you memorize those and then she'll tell you what the amino acid is. And then you're like, okay, this isn't a hydrophobic one. Use the neutral equation. So with the neutral equation, typically the hydrophobic ones won't really give you a PKR. So she won't provide the PKR. Does that make sense?
Yes, thanks.
You're welcome. Any other questions before I pass it off?
Hi, Phoebe. I have a question.
Yeah, go ahead.
So going back to the one with where we have to use the Hamilton-Hasselbalch equation.
Yeah.
So just conceptually, I'm trying to understand it. Would you just have to know pretty much the bicarb, carbonic acid bicarb buffer system? Could that help you? Could that help you get or eliminate some of the answer choices? Because you're saying that there's the pH drop. That means there's an increase in hydrogen atoms, and then that's also associated with an increase in bicarbonate, correct?
Yeah. So I mean, you could reason it out that way, but
okay.
Yes, but you would have to know the math for it too. So
I understand. Yeah, that's the first thing I jumped to when I was starting to read the question. So I was thinking about the equation, the buffer system.
Yeah. So yeah, you could definitely eliminate some answer choices with that reasoning. But
okay.
Yeah.
Okay. All right. Thank you.
You're welcome.
I just have like a side question. I'm not sure if it's been like addressed before, but will we get like, are these all like in our head type math problems, or will we be able to use like if we're doing it online, like how will we be able to answer these questions?
I mean, we weren't allowed to use calculators our year, but we did get scrap paper. I don't know if they're going to give you the option for like the little whiteboard that Proctorio provides, which is totally not helpful if you don't have a touch screen and you have to like type. But I honestly don't know what they're going to do this year.
Okay. Okay, thanks.
You're welcome.
Hey Phoebe, I have a question on the synthesis of the collagen fibers or fibrous.
Which one was that one?
Well, I guess this is just in general with like the synthesis of it.
Yeah.
So I just need reassurance on that. The whole reason that we hydroxylated it was the amino acids was for to add the sugar group, correct?
So only for the lysine. So yeah, if you hydroxylate a lysine, say you hydroxylate 30% of the lysines on the strand, you can glycosylate those lysines or hydroxylysines now. So you wouldn't glycosylate all of them, but say you glycosylate half of those. So 15% of the hydroxylysines are now glycosylated. Does that make sense?
Yes, and then so the OH group would just be there, like it wouldn't have an effect on it.
Oh yeah, no, the OH group is necessary for the glycosylation because it forms that ester bond that connects the sugar.
Oh yeah, but also like because it said I have on my notes that not all of them get glycosylated. Not all OH groups get glycosylated.
Right, yeah. So some of the OH groups will just kind of hang out there similar to the hydroxyprolines. They'll just add stability by themselves. And then some of them will get glycosylated.
Oh, okay. Okay. Thank you.
You're welcome. Any other questions before I pass it off? Nope. Okay. I think, Ivy, it's your turn.
Hey guys. So I wanted to quickly mention that we reviewed the image that wasn't showing up for some people, and it was uploaded correctly. So if you had an issue with opening that image or not being able to view that image, then next time just try to refresh your browser, because all the answers you've entered up until then will be saved. So refresh your browser and see if that works, because I can't do anything differently to make it appear for you guys.
Hey, Ivy, I actually emailed Rose about that because I did click refresh on my page, but then it said, do you want to leave the page or stay on the page? And I chose to stay on the page because that sounded like it was going to kick me out of the quiz.
Yeah, you have to select leave the page, and then it will refresh, and then you will get redirected, and hopefully it loads.
So clicking leave the page will not kick me out of the quiz. You're saying it'll just refresh the image?
Mm-hmm. Yes.
Okay, if for some reason I am kicked out of the page, is the quiz still live because I started it already?
If you are kicked out, then I would email Rose, because I don't know what else to do about that. She just told me that she went in and looked at it. I had submitted the image into the quiz correctly, so there was nothing else I could do on my end to try to fix it. She said just refresh. And I think when I was in your shoes, I had to refresh a couple times once we switched to online, and I would select leave the page and I would be redirected.
Okay, I'm noticing in the chat, is it an issue with a browser? Like you have to use Chrome, not Firefox? And
Yeah,
that's
you have to use Chrome. As Dr. Barber said during orientation, everything for Canvas and Proctorio when you're taking your exams will be through Google Chrome.
right, but this wasn't a Proctorio one, so anyway, okay, thanks.
Okay. Okay. I'm going to screen share, and we will start. All right. So the first question looks like you guys did pretty well. What carbon position on the sugar indicates if the sugar is ribose or deoxyribose? So that's going to be the 2' carbon on the sugar. The 3' carbon is always going to be a hydroxyl group, whether it's ribose or deoxyribose. The C1' is always going to be the glycosidic bond, and the 5' is going to be where the phosphate is bound. What does a nucleotide consist of? So we know a nucleotide is the base, the sugar, and the phosphate. And we know that the nucleoside consists of the base and the sugar. So in turn, the nucleotide is consistent of the nucleoside and the phosphate. So the correct steps of PCR. When we do a PCR method, we're going to first denature our strands so that we can have access to the segment that we want. We introduce our primers, and then from that primer, we have a free 3' hydroxyl group that will allow DNA polymerase to synthesize new strands. So then we get DNA synthesis, and from there we repeat those same steps over and over until we have the desired quantity of DNA. So next, we have two exactly identical copies of DNA attached at the centromere are termed sister chromatids. They're termed sister chromatids because if they're exactly identical copies, they're sisters, and they're chromatids because they're still attached at the centromere. Okay, this is the image in question. I don't know why it didn't show up for some people. It was inputted correctly. I don't know. We'll keep looking into it, but Rose and I discussed, and I don't know what else I could have done differently. But in this image, we have 3 chromosome pairs depicted. So for chromosome 1, we have 2 homologs. For chromosome 2, we have another 2 homologs, and for chromosome 3, we have another 2 homologs. So that is a total of 6 homologs. Now, if you wanted to count the sister chromatids in this image, there's 2 sister chromatids for every homolog. So 2, 4, 6, 8, 10, and 12.
Hi, Ivy. Just to be clear on terminology for that question. So if you say homolog, that is the same as chromosome. If you say pair of homologs, that's your maternal and paternal. And if you say sister chromatids, that's the identical DNA replicates, correct?
Yeah, yes. So if he were to ask you how many pairs of homologs are there in this image, then you would say 3 pairs. But if he asked you how many homologs, then you would count each individual. And then if he asked you how many sister chromatids, you would count 2 for each homolog, because you know whenever we do a karyotype, we're using a metaphase chromosome. So each chromosome has duplicated its DNA in order to prepare for mitosis.
If he were to ask how many chromosomes are present, would the answer be 3 or 6?
It would be 6.
Okay, thank you.
One more question. So a chromatid singular. I'm sorry, I cut out. So a chromatids plural is sister chromatids, correct?
Yes. So
would
this would
chromatids
be
singular be just a chromosome, just a single strand?
No. If he was going to ask you and he wants you to identify the chromatids on this image, he would say how many sister chromatids are present because they're attached. So he wouldn't want you to just count 1, if that makes sense.
Okay.
If he wants you to identify sister chromatids, he will give you maybe an image like this, and you would have to know that there are 2 sister chromatids in each homolog.
Okay.
Thank you.
And then for this one, it would be like 6 metaphase chromosomes.
We should really stick with homologs or sister chromatids because that was like the major differentiation point he wanted you guys to make. But each homolog, so this is 1 chromosome and this is 1 chromosome. We term them as 1 chromosome because the sister chromatids are still attached at the centromere, but once they split apart, then each individual sister chromatid will be considered a chromosome. Does that make sense?
Yeah, thank you.
Just to go over one more time, sorry. When you said like if you ask for the sister chromatids and there would be 2, that means the answer would be 6, correct? Since there's 3 pairs.
If you ask
how many sister chromatids are there and it was the same picture, would the answer still be 6?
No, because there are 2 chromatids for every homolog, so that would be
12. So it would be like 12. Okay.
Yes.
Got it.
Okay, good. Is there another question on this? Okay, moving on.
If he says chromatids, there would be 6, right? Chromatids. Okay. Can you hear me? Or not? Hello?
You're cutting out a little bit.
I'm saying that if he says that there's if he asks you how many chromatids there are here, there'd be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 12 chromatid, but there'd be 6 chromatids, correct?
No, there are 12 chromatids in this image. The term chromatid refers to sister chromatids attached at the centromere. If it's not attached, it's considered a chromosome.
Okay, gotcha. Thank
Does
you.
that make sense?
Yeah, that makes sense. Thank you.
Okay. All right, moving on. Histone proteins have a blank charge due to their blank residues. So histone proteins have a positive charge due to their arginine and lysine residues, and that's what allows histone proteins to interact so closely with negatively charged DNA. Looks like you guys did a good job on that one. During what stage of the cell cycle are histone proteins synthesized? So histone proteins will be synthesized in G1 when we're preparing to replicate our DNA, because if we're going to replicate our DNA, we're going to need all of our histone proteins already synthesized. So once we do replicate that DNA can wrap around those histone proteins. And we know that DNA is synthesized in S phase, and G1 is preparation for DNA synthesis. So they're going to be synthesized, they're going to be synthesized in G1. Next, which of the following proteins facilitates the processivity of DNA polymerase delta? So you guys did a great job on this question. It's pCNA, because pCNA wraps around the full DNA helix. And if DNA polymerase delta has binding with pCNA, it's not going to fall off of that DNA. And that's why it's able to synthesize nucleotides for really long stretches. Which of the following describes the role of topoisomerase on DNA? You guys did it. Relieve torsional stress. So when helicase unwinds the DNA to allow for access of the DNA for replication, it causes all this torsional stress and supercoiling further down. So we need topoisomerase to go in, nick one of the phosphodiester bonds on that DNA so that the DNA can spin around itself and return to its desired state, which is going to be 1 turn for every 10 base pairs. In a functional gene knockout experiment involving the loss of DNA polymerase epsilon, what effect might be observed? Good job, guys. No effect, because when they did that experiment and they knocked out DNA polymerase epsilon, they figured out that DNA polymerase delta will just take over. So it's just a redundant polymerase. And that's why he said in lecture that DNA polymerase epsilon is a decoy on the exam. So true or false, the RNA primer made by primase will be found in the final DNA product. That's false. That's the whole reason why we have the enzyme RNase H. Which of the following enzymes does not possess the 3' exonuclease ability? That's going to be DNA polymerase alpha. So I will pull up that slide for you guys. So here we have exonuclease, 3', that's epsilon, that's delta, and here's alpha, and we don't see that on the slide. So I will get back to the chat to see if we have any questions. Okay.
Hey, Ivy, can you explain that again? Because there was a lag on what was viewed.
The last question? Was it the last question you wanted, or?
Yeah, it was the last one.
Okay. Let me screen share with you again. So the last question was, which of the following enzymes does not possess 3' exonuclease ability? So that is actually on the slide as DNA polymerase alpha, and I'll pull it up for you right here. We have polymerase delta and polymerase epsilon, and they both have it circled right here, but alpha does not.
I still can't see what you're showing us.
You can't see my entire screen, or you can't see.
I just see the like the test part. I don't see. Oh, now it showed up now. It just showed up. The thing that you were circling.
Yeah, so down here at the bottom, we see epsilon, then we see delta, and they both have it circled there, whereas alpha does not. Okay, I'm looking at the chat right now. S phase is where DNA is replicated and G1 is histone synthesis. Yes, that's correct. The answer to 42. What question was 42? Ours are not numbered.
'42 is the one about histone proteins and their charges.
Okay. I'm just going to keep screen sharing and pull up the chat on my phone. This one. Okay. So histone proteins have a positive charge, and that's due to their arginine and lysine residues. That's so that they're able to interact with the negatively charged DNA.
Hey, I'd be going back to the processivity question and the proteins associated with processivity. Wouldn't RFC and PCNA be part of the same complex? So wouldn't they essentially be the same? That question was kind of confusing.
Yes, but you have to remember that he said during lecture that they are both decoy answers. So not to select them on the test. He wants you to know PCNA, and he said if you see RPA or RFC, that they're decoy answers.
Okay, all right.
Mm-hmm. Any other questions, guys? I see a lot of stuff in the chat about the picture. I don't know. I'll keep talking to Rose about it, but I don't know what else I could have done differently.
Hey, Ivy, I have a silly question. If that had happened on like a real exam and a lot of students couldn't see the picture, how would they have dealt with that?
So that has happened on exams previously, because you will get, I know for genetics, you will have pictures. And for some people it didn't load and others it did. But when we were taking exams in person, you would just call over one of the exam proctors. But since you guys are online, I would just email the instructor and let them know that the picture did not show up for you. And they're pretty good about being fair with that.
So we'd email like the professor, not Rose?
Correct.
And I've never worked with Proctorio before. Is there any way we can take like a screenshot of our screen, or because Proctorio like takes over, we can't do anything except like click the answer?
No, so you can't take a screenshot of your screen. I know once we switched to online, I had a couple issues with Proctorio and crashing on me, whatever, but you can't take any screenshots. They just have to go back and I guess they can view what happened during your exam or something like that. So you would just email the course director.
Okay, so it would just basically be an email to them and then wait for their response, and they're usually understanding or...
Yeah. Any other questions, guys?
Someone had a question in the chat.
Can you go over HP1 on the which question? Which question was it?
I think HP1 was just in relation to the histone that causes the chromatin condensation or condensation, not an actual question on the quiz.
Oh, I see. Okay. You guys can still see my screen, correct?
Yes.
Okay. So you want me to go over this topic. So when lysine 9 is methylated, it matches this protein we term HP1, and HP1 has like a lot of self-association. So since it has a lot of self-association, they'll get even like closer together, even wound tighter. So it will be associated with no transcription, since we will have our chromatin like even more condensed. So we will go to looking like this at the top, tightly associated with itself, condensed. And if we go down to, or it might be up here, there's no RNA transcription in condensed chromatin. Does that answer your question? Okay, good. Any more questions, guys? Still have one more section of the quiz to go over. So if there's no more questions, I'll pass it over.
Good afternoon, everyone. So we'll go over the immuno questions now. Before I go over the immuno questions, when I was looking through the data, the item analysis, I did want to point something out. It seemed that essentially right after my questions and then most of the way through Justin's questions, that the number of unanswered questions increased dramatically. It went from about 4, then went to about 12, and then went to about an average of 20 people not answering questions. I'm not sure if that's people running out of time or people just kind of throwing in the towel, but I would definitely recommend going through this without your notes and using it to see kind of where you are. So that way you can adjust your studying and see which subjects you need to work on the most. So just make sure that you do that. I know that y'all had issues with the image. And like Ivy said, she did everything that she could to put it up there, and going through all the IT on our side, we did everything that we could. It is a shame that many of you had that issue, and hopefully that doesn't come up again. But for right now, just try to make sure that you go through and really give this a strong test when you're doing these practice tests. All right, so our first question, everyone seemed to do pretty well on it. Can everyone see my questions?
Yeah, we can.
Yeah.
Okay, thank you. So the very first question, pretty simple. We're looking here, a patient comes in, they have an immune response on their arm. They think it might have been some sort of reptile. They don't know what occurred, but we do give them antibodies. So we know that giving them antibodies is in itself a sense of passive immunity. So everyone did a good job on that one. Our second question, the same patient, we're looking at this same patient that is receiving antibodies, and we want to know what is not a benefit of this treatment. So when you go through to answer this question, make sure you're thinking about what is and what aren't benefits of this treatment. You'll see throughout the test that you're going to get a lot of questions that have nots in them. Make sure to notice it. That's something that trips people up very easily. We do know that antibodies are very easily administered. They are very fast acting. They don't stay around for a long time. They do not stimulate an immune response. So that's pretty impressive, and that's important when we're thinking about that. And then they do not induce memory. So that is going to be the big thing, that they don't induce memory. So when we are doing antibody treatments, we talked about it in the review that for the convalescent plasma that they're using for coronavirus, we're seeing that it's actually not giving you that long-term immunity. So that's something you need to remember when we talk about antibodies. All right, our third question. This is one that actually was just a copy and paste from the review session. So if you went to the review session, you saw it, and we went over it, made sure to stress this, that we're talking 5 to 10 days here for when a B cell will start making antibodies. Remember, it is our B cells, and they differentiate into plasma cells, and at that point, they start making those antibodies in 5 to 10 days. That's a pretty strict window. The window is closer to 7 to 10, but it can range from 5 to 10. Okay, so this is the first one where we had a slight difference in some of our statistics here. So the question, a B cell receptor is an example of an antibody. The portion of the antibody that is attached to the B cell itself is the constant region of the heavy chain. So remember, the variable region, that's going to be what binds to the antigen. The variable region has two parts to it. It has a heavy chain region and a light chain region. The constant region is also known as our FC region. So this is the one that's actually binding to the outside of our B cell. The FAB region can consist of the light chain, the variable region, and then the hinge region is just that point that's made of disulfide bonds that allows us to change when we're going through class switching. Our next one here, goal of education. Like I said in the review, we're going to be seeing a lot more of T cell and B cell education, but it's a good thing that y'all remembered the T cell for thymus, and the whole point of education is to avoid autoimmunity. Here is our next one. So you're an infectious disease resident experiencing your very first patient. They come into you with blood culture results inferring an extracellular bacteria. So the moment you read that, before you even get into the rest of the question, your brain needs to think extracellular bacteria. That's going to be an exogenous antibody. Right there. It's outside of the cell, so it's exogenous. So then you go through and you think exogenous antibody. That means that's going to lead me to a CD4 positive T cell. And then that's also going to lead me directly to antibodies being made. That CD4 positive T cell is the one that helps the B cells. That's the one that allows the B cells to engage in class switching and isotype switching for our immune globulins. So if you go through that process, then once you get to the actual question, which cell type is most reasonable, we know that it's going to be a B cell. Remember, eosinophils, that's going to be for allergies as well as parasite infections. CD8 is going to be for endogenous antigens, so viral infections and intracellular bacteria, as well as tumors. And then NK cells, they're going to be part of our innate, and they're just kind of going around looking for those as well, viral infected or tumor cells. So make sure you differentiate here between the extracellular and intracellular infections with those antigens. This one seemed to trip people up. I know she kind of glossed over this in the lecture. It is pretty important to know what each immune globulin does, so what each IG does. So remember, IgD, it sticks to the cell surface and stays there. It doesn't have a direct action. It works more as a helper. IgG, that's going to be your most abundant one, and it's the most used. IgE is going to be for allergies, and then IgA is going to be your mucosal. So you're going to find this in your nose, the mouth, any genitourinary region, and some areas in your gut. Our next question, which correctly profiles the innate immune system? So we talked about this a little bit in the review section. Make sure that you have those differences between the innate and the adaptive. So your innate is going to be very fast acting, and it's not specific at all. So knowing that, we can kind of narrow down some of these answer choices. Slow response, that's adaptive. I'm sorry? Okay. So then the innate system, like I said, it's very fast acting and it's very generic. It's not specific at all. So that can help us narrow down these answers here. Rapid generic response, like we said, that's part of the innate. And then PRRs, these are what we have on our innate cells. So like the examples being the toll-like. So make sure you can differentiate those two systems.
Can you go over why number 1 is wrong, the pre-existing mechanism and the classical complement system?
Yes, so the classical complement system needs antibody presentation. So remember, we had two parts of our complement system. We have the classical and the alternative. The alternative would be more linked to the innate immune system because it doesn't need the antibodies present. The classical, on the other hand, needs the antibodies. So it's going to be a little slower, but it's going to be part of our adaptive, because at that point we're creating the antibodies to then initiate that complement system. Does that make sense?
Yes, thank you so much.
No problem.
So if you had put alternative complement system, that would have been a correct answer.
Yes. All right, so our next question, which of the following cannot react to an antigen without formal presentation? Dr. Pross harped on this very, very strongly. It's the cytotoxic T cell. So T cells themselves always need formal presentation. Now, I also could have put here helper T cell. Remember, your cytotoxic is your CD8 T cell. I could have put CD4 and it would still be correct. So make sure you know it is T cell specifically that needs antigen presentation in order to actually activate. And then this next one, this is kind of the same stem that we used in our Wednesday review. The world is currently consumed with coronavirus. As we go through it, knowing the mode of infection, what MHC class is used by the body in the defense of coronavirus. Remember, our MHC class is directly linked to which T cell we're going to be using. So MHC class 1 is going to be endogenous antigens. So there's going to be viruses, tumor cells, as well as intracellular bacteria. And that will automatically link us to CD8 cells. So whenever we see virus or tumor, the first thing that should pop into your head is class 1 and CD8 cells. Then if we see exogenous or any sort of extracellular bacteria, it should immediately go to class 2 with CD4. So make sure you have that in there. Innate uses. So the innate is going to use pre-existing mechanisms. That's going to be our PRRs. So make sure that you recognize that the PRRs are pre-existing. They are there. They're part of our germline. They get passed down. And that's something that can trip a lot of people up. But make sure you know the difference between those complement systems. All right. And then this next one here, if you got the one prior to it, the class 1, that should give you a hint to the next answer. So the next answer is wondering what transport peptides we use for this MHC. So you had to have been able to get the first one to get this second one. When we go through it, we do see in the lecture that she goes through and says that the TAP and Tepacin are used for MHC class 1, and then CLIP and the invariant chain are used for MHC class 2. So make sure you know those differences. You definitely need to be able to correlate these transport peptides and skip 10 steps and go immediately to what type of antigen is being presented. You need to be able to process there that what type of antigen and then link it to all the information that goes with that antigen. So the incoming coronavirus, Ellen, to answer your question, any sort of virus is going to be an endogenous, because the way a virus replicates is going to enter our cells, and then while it's in our cells, it's going to be reproducing. As it's reproducing, our actual cells, the internal mechanisms, will recognize that antigen that's being produced from within our cells, because they can't replicate outside of our cells. So all viruses are automatically going to be endogenous antigens. Okay. And then the process of inflammation. This is our last question here. I did go over this a few times in the review. You need to make sure to note how the inflammation process works. This is going to come up in multiple classes. So it starts off with that leukocyte or lymphocyte rolling throughout the vasculature. Then when the macrophage or dendritic cell, whatever APC is on the outside of the vasculature, notices that antigen, it'll release cytokines. That cytokines will then activate integrins on the endothelial cells. The endothelial cells will then release chemokines. Remember, the chemokines work as an attractant, so they're going to attract those leukocytes or lymphocytes to actually get onto those endothelial cells and bind to those integrins. After that, then we have full adhesion, and we'll talk more about full adhesion when we get to the interactions with the T cells and the SMAC complex. Once we have that adhesion, then we'll deal with migration, where those leukocytes actually migrate from the vasculature into the tissue that needs that immune response. So that's all of our questions. Like I said, everyone did pretty well on mine. The data is skewed a little later on. As you can see, it started where we had, I think it was maybe 4 to 6 people didn't respond, and then the number just kept going up, 11 all the way getting down to about 20. So that's pretty staggering. Make sure that you take your time to actually go through these questions. It's super important. We're putting all the work in to make these questions to kind of prepare you for the test and help you get an understanding of your studying abilities and see where they are. So please try to do it. And then does anyone have any other questions?
Yes. Can you go over IgE function and then explain again the difference between chemokines and cytokines one more time?
Yeah, so IgE specifically works with allergies as well. It works with helminths, so intracellular parasites. So anytime we have any sort of allergy response, and you'll get into it later in block 3, when we get into specific worms or parasites that live in the body, we're going to be using IgE as a response to that. So that's the only one that we really use for allergies. And then the difference between cytokines and chemokines. Cytokines are small peptides that we use, that the cells use to communicate, and they use them to initiate a response in a cell. So whether it be an autocrine response, so it's releasing it to tell itself that it needs to proliferate more or stop a certain process, or it's a cytokine that's going from one cell to another to say, hey, put this receptor on the outside of your cell membrane. A chemokine is an attractant. So it's the same thing. It's still a cytokine, but it's a cytokine that specializes in telling a cell where to go. It's telling cells that we need you here. We need leukocytes here. We need neutrophils at this site here to deal with a problem that we might have.
Thank you.
No problem.
I had a question on number 11. Could you go back and just review what the other two do besides Tupacin?
Yeah, so we're going to go over it a lot more when we actually go through the lecture. This was something that we didn't go through in my review, but we are going to go through because Dr. Prost just finished this lecture yesterday. So TAP and Tupacin just essentially break down that endogenous antigen and put it up for the MHC class 1 to present it. The invariant chain, so big I, little I, and CLIP also do the same thing, but they do it for the exogenous antigen. So they do it for MHC class 2. And then the same thing for invariant chain and DM. They do something very similar, but they do it in a different format. So we're going to go over that when we go through it in the review. The main ones that you have to remember are TAP Tupacin for class 1, and then invariant chain and CLIP for MHC class 2. Does that clarify that up a little bit?
Yeah, so invariant chain and DM, are those like the same thing then?
They're not the exact same thing. They do work in a different order. Like I said, we'll have to go through it more when we can actually have the slides there. We can go through specifically what they do. We're not too concerned, and if you look at her objectives, we're not too concerned with DM. We're more concerned with CLIP.
All right, thank you.
No problem.
Appreciate it, man.
No problem.
Hey, Daniel, maybe I'm just having a brain aneurysm, but what's the difference between invariant chain and CLIP? I thought they were like the same thing, but different parts.
So yes, they are. They're different parts. The same thing with TAP and Tupacin. So they all do the same. They all do the same idea, but they do it slightly differently. So one is leading to the other. So it's essentially like an assembly line. So if we have an assembly line and we're building something, let's say we're building a toy car, you're going to have one piece of the assembly line that puts the wheels on, and then another one that's going to put the cover on. So that's how we look at TAP, Tupacin, and invariant chain and CLIP. One of them, so TAP and invariant chain would put on the wheel. Then Tupacin and CLIP would put on the cover on the car. So they're all going to the same end goal, but they're doing something different in the process.
Okay, thank you. And the one part, the CLIP is what's in the cleft of the MH2, correct?
Yes, yeah, for MHC class 2. So CLIP is actually going to be, it's sad, but it actually works like a clip where it's going to take that broken down antigen that we have gotten from the invariant chain. It's going to actually grab onto it, and then that's going to go to the cell surface to then exchange it and put it onto the MHC class 2.
Thank you.
No problem. All right, let me see if I can do some of these in the chat. Some people have answered some for me. So T-cell dependent antigens, we're going to go over that. That's something that we didn't really touch as much in our review because she hadn't gone through that point of the lecture. But T-cell dependent antigens are going to be peptides. So it's ones that are mainly going to be endogenous, and we have to cover it again when we get to vaccines as well. But we'll go over that more on Wednesday. And yes, for cross-presentation, that is a very, very strong exception. You have to remember cross-presentation is almost the exact same process as an endogenous antigen, but that antigen that was built inside the cell has been exported outside the cell. And now instead of the cell that's infected itself presenting the antigen, an APC, so mainly a dendritic cell, will present the antigen. But it ends up in almost the exact same pathway as the MHC class 1. So I think, let me go over a question. Variable portion. Okay. Everyone's doing a pretty good job of answering my questions for me in the chat. So does anyone else have any other questions, or did I miss someone's question in the chat?
I have a question. Could you go over the second problem about AB sera again?
Sure. So the second question you were saying?
Yes.
Okay. So in this question, we already kind of went through it, that we're using, it says in our question stem that we're using antibodies, right? And sera just being the serum from when you spin off the whole blood. So to answer this question, you need to understand what antibodies do, and then deduce from there which of these is something that they don't actually do. So we know antibodies can be administered quickly, so that eliminates easily administered as an answer choice. We know that antibodies, we can just direct inject them, and they can help take care of the problem. We also know that they are fast acting because they're already preformed, that we can just directly inject them, and then immediately they're already working on attaching to that antigen and then signaling that antigen for apoptosis or phagocytosis in any way that we actually might get rid of it. We do know also that they're not going to actually stimulate the immune response. So they're not going to actually cause inflammation because they deal with, they're very, very specified. So we're not going to have an increase of macrophages or neutrophils coming to that area, causing that inflammation, causing that heat, or causing that issues with the loss of function with nearby cells. So knowing these three things that antibodies do, we can then deduce that memory inducing is not one of them. We should also remember from the lecture that antibodies themselves don't induce memory. In order to get memory induction, we need the adaptive immune system. And if we're just giving someone just antibodies, just straight outside antibodies, then we're doing passive immunity, which is not really going to give us that adaptive response, that active immune response that will allow us to create our own antibodies. So the only time we're actually inducing memory is when we're creating our own antibodies. Does that explain that one for you?
Yeah, it explains it. I think I was just confused about how no immune stimulation is a benefit.
Yeah, so and that one's a little tricky. That I put that one in there just to kind of throw you all for a loop. I'm sorry, but I kind of have to do that. So no immune stimulation. What I mean by that, and what the professors are going to mean by that, is we're not having that erratic immune response. This is much more controlled. So that immune stimulation that we're going to get in other facets of immunity is when we are getting that inflammation response. That inflammation response just being when we have a whole bunch of macrophage and neutrophils that are getting through that endothelial layer and getting to the site of action and attacking. And remember, they don't attack with any sort of specificity. So they just attack anything, which is going to cause that loss of function. So if we have too much of an immune response for too long, that's when we have chronic issues of inflammation, and we can lead to any sort of disease and loss of function. So that's kind of the distinguishing there.
Thank you.
No problem. We got a lot of people in the chat now. So which is the region, the antibodies? So yeah, the FAB is where the antigen binds. So you can kind of remember that as F. So just F is the actual function, and then antigen binding region. And then FC, that's going to be our constant region. So the FC is constant. It's not the variable region at all. The FC region is the constant region that's binding to the actual B cell membrane. And yes, the FAB region is both, it's the variable light and variable heavy chains. Does anyone else have any other question? All right, so if no one else has another question, I will probably sign off.
Hey, no, actually, yeah, I have one question.
Sure.
So I was scrolling through the slides to see where she went over the functions of the different immunoglobulins and the locations you can find them. I couldn't find where she was discussing that.
So she said it.
Okay.
So with her, and I kind of mentioned this in my, I mentioned it in passing in my review, with Dr. Pross and with some of our other lecturers, it's very important to pay attention to what they say, not just what's on the slides, because they use the slides more so as a skeleton or an outline of what they want to get across to you. What they say is what's coming to mind when they see these slides. So they're using the slides as a way to remember the information, as like a recall. And then what they say is the specific details that they want you to know. So she kind of mentioned it in passing. It's something we're going to go over more in the upcoming slides, but just kind of, and I have it on my slides that I put on Canvas in the TA group under the modules. So make sure that you know the differences between them, even though she kind of mentioned it in passing.
Okay, thanks.
So, and I think, I'm guessing that Ivy wants to give you all a little note here at the end. Yeah, so everyone have a good weekend. Try to keep up the studying. Don't take too much time off. And I'll let Ivy finish it up.
I just wanted to go over this again because it seemed like we were struggling a little bit with this concept. So I just Googled a picture for you guys. So all of these 4 are considered chromosomes, which is why if he wants you to identify a homologous pair or sister chromatids, he's going to ask you about a homologous pair or sister chromatids. So homologous pair are like chromosomes that you get from your mom and your dad. So they're not exactly identical, which is why we consider them different chromosomes. And the sister chromatids are when that same chromosome duplicates itself for preparation for mitosis. And they're still attached right here at the centromere, which is why they're termed chromatids instead of chromosomes. So if I look at this side on the left, I have 2 chromosomes here, but I have 2 homologs. 1 homolog from my mom, 1 homolog from my dad. And if I look at this picture here, I still have 2 homologs, 1 from my mom and 1 from my dad, but now I have 4 sister chromatids, 1, 2, 3, and 4. So hopefully that clears some stuff up for you guys. Yeah. That's about it for me. If any of the other TAs want to say something else.
Thank you, Ivy.
You're welcome.